Well, hello, everybody. Good afternoon, good morning, depending on where you are in the country. My name is Garrett Schmidt. I am the CEO and managing editor of VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Patient 360. And this one is called Key Concepts in the Recently Released CMS Proposed Rules. There's a lot of information we're going to cover today, so we're going to dive right in here. A couple housekeeping items before we get started. Everyone is joined today in listen-only mode, so this is a traditional webinar format. You don't need to turn off your microphone or your camera, but we do want to hear from you, though. We are going to have a time for some Q&A. However, just as sort of a pre-warning, we've got, again, a lot of content to cover today, so if we get to where we get to Q&A and we don't have a lot of time for audience questions, don't worry. Someone is going to reach out to you via email to make sure that your question gets answered. So go ahead and drop your question in at any time. And again, if we don't get yours in this session, don't worry. Someone will get to you. Finally, the session today is being recorded. So when we are done, what's going to happen is about an hour or so after we conclude, you will receive an email with a link to the recording as well as the slides that you can download and review as well. And that way you can share it with colleagues and friends and review it again. And you probably will want to because it's pretty dense and there's a lot in there that you're going to want to go over again. So without further ado, wanted to first of all actually introduce Patient 360. Patient 360 is a founding registry dating back to the PQRI and PQRS days of quality reporting that later evolved into MIPS. They're also one of the first registries to support APP reporting use case for ACOs since the program year's inception in 2022. They also support multiple QCDRs in the MSK and pain management specialty and are recognized nationally as thought leaders in the space. And they are definitely an impressive organization, so I encourage you to research them afterwards. But our speakers today, we have with us Ms. Amanda Lord, and she is the COO and principal at Patient 360, and also Ms. Deanna Hayes, who is the clinical quality director. So without further ado, I will pass it over to you two. Welcome.
Awesome. Garrett, thanks for the warm welcome, and welcome to our attendees. So before we officially kick off here, I just needed to briefly highlight, I know it's a disclaimer, but we've got to do this. We want to remember that we want to remind you to just really check the direct sources and always verify with CMS. It's really important to do that. We aren't CMS staff members, so we're going to make best efforts today for you to provide you with very useful and accurate information, but just wanted to make you aware of our disclaimer. Next slide, let's just walk through our agenda. So one important item that I really want to quickly address about our topics in our session today is intent with you. Our intent isn't to merely just provide you with an abridged and regurgitated version and summary of the proposed rule. Most folks can glean the basics from the fact sheet, which we've all had our hands on, and from attending the QPP calls, which we do all the time. And they do exactly that. They do provide an overview. And of course, we're going to have basic information about the key highlights within the proposed rule. But what we really hope to achieve today with you is we want to walk away from this call having some very specific and actionable items, and for you to understand the why and the how some of these proposals may affect your organization and what you can do to ensure your voice is heard if you have some strong opinions on any of these proposals. We are going to spend a significant amount of time on the ambulatory specialty model, that third bullet down there. Of course, we're going to spend time on MSSP, MIPS, and MVPs, but there haven't been any earth-shattering changes for those programs. So we're going to go through the programmatic changes and those nuances and then really spend a good chunk of time on the new ASM model. So with that, we do know that you have busy schedules. We really appreciate you joining us today and giving us your time. And we value your time. So we're going to delve right into everything. And first, Garrett's going to do a quick poll.
Okay, so we have a poll. We wanted to hear from your audience, or from our audience rather, and putting this up on your screen. How familiar are you with the 2026 physician fee schedule proposed rule? Is it, and this is anonymous, by the way, so feel free to be honest. But we're going to show this and see how kind of where you stack among your colleagues, because it's sort of good to know. This is obviously very new, so I don't expect a whole lot of you to have read the entire document. but we're just curious as to how familiar our audience is with it, and that will help us to kind of gauge what areas to focus in on a little bit more. So that, again, the questions are: I've read most or all of the document. I've read some. I've released the key highlights important to my organization, or I've read little or none of it. And again, any of those are killed. All right, I think most of the results have come in, so I'm going to go ahead and share the results here. All right, Amanda, are you able to see those results
Yeah.
on your screen?
Yep, got it. Well, I'm really impressed with those 4 there that have read most or all of the entire document. Whoa.
Yeah, me too.
I think everybody's kind of in that middle section, but there are a number of folks here today that haven't read it at all. And that's okay, because we're going to go through everything step by step, walk through this with you shoulder to shoulder, and make sure that you understand the concepts. And again, that you walk off this call not just with, well, what was it about and what are the key highlights, but how do they impact me? What can I do about it? So with that, let's go ahead and continue on. Just quick note here on the slides, the page number references, how to understand our page number references on these slides that you're going to see, most of them. The page numbers are directly from the published version of the proposed rule. And for your convenience, when we reference a page number, we're going to cite both the PDF page number first and then the federal regulatory page number, because there's an unpublished version floating around. And so I just wanted to provide that delineation that when you see page numbers on here, we're providing the PDF version of the published version of the page numbers and then the federal regulatory number. Next slide. All right, so now we're really going to get started here. We're going to begin with our MSSP proposed updates. And overall, there's, like I said, not a lot of drastic proposed changes for MSSP ACOs specifically, but there's a lot of small proposals that certain groups listening in might find important. So first, for participation, the 5-year limit. That's going to be for one-sided risk model participants, and that's going to start with agreement periods beginning on or after January 1st, 2027. So why are they setting this limit? Essentially, this proposal is intended to encourage participation in two-sided risk models. So they want that shift to occur within 5 years. They want you to evolve and graduate to a two-sided risk model. Of course, they acknowledge that they've changed the time limits a few times. A couple of years ago, it was 7 years. It's gone back and forth from 7 to 5 years. But at the end of the day, they want you to make this shift into the 5-year model. So if you're currently in a one-sided risk model, we've provided the page number where you can learn more about the aspect of the proposal and comment accordingly if you're concerned about the 5-year limit. But again, for the most part, they really do want ACOs to ramp up faster and move from that one-sided model to the two-sided risk model within 5 years. So next, slide to the right regarding CHOWs. So CMS acknowledges change of ownerships, right? The request cycle happens once a year. That's really, really limiting for most ACOs. So they're proposing a bit more flexibility for this, specifically for ACOs that have TINs with a change of ownership outside of the change list to reflect participants. They're gonna do it basically within the request cycle, be able to update it so that you don't have to wait to do it once a year. This does apply to instances in which the ACO participant has undergone a CHOW resulting in a change to its Medicare enrolled TIN, whereby the surviving Medicare enrolled TIN has no Medicare billing claims history. So it's a very specific circumstance there. In this case specifically, the ACO can submit an ACO participant change request for a CHOW resulting in a change to the TIN throughout the performance year, no later than 30 days after the CHOW and outside of the change request cycle. I also want to note that the CHOW proposal does not apply to a CHOW in which a TIN is absorbed into an existing TIN and the surviving TIN has prior Medicare billing claims history. So that's just an important thing to delineate as well. And then if you take a look, there's other CHOWs related to modifications of SNF affiliates proposal, and that's only going to impact SNFs that are approved as affiliates to provide care without the required 3-day hospital inpatient stay. So if you're listening in and you have SNF affiliates that are contemplating joining your ACO or the SNF change TINs, this is important because it's more flexible. They can join and maintain the 3-day stay waiver because SNFs tend to change ownership fairly regularly. So this should probably help you. So this slide, why is it important? It's important for larger ACOs who have or know they will be experiencing potential TIN changes during the performance period. There is more flexibility, but you may want to comment for CMS to expand their participation change parameters if you have additional circumstances that require you to make changes in participation throughout the year. So these are very specific reasons for changes. If you have other reasons or other participation parameters or scenarios that are going to impact you, that's what you may want to comment on. Because these are more flexible, this is going to help most folks, but you might have other parameters and issues with change of ownership that are impacting you that are not really related to these. That's what you would want to spend time commenting on. Next slide, please. So eligibility for smaller ACOs. There's going to be some flexibility for smaller ACOs. So CMS is proposing to allow ACOs to enter the shared savings programs with fewer than 5,000 assigned beneficiaries in benchmark year 1, benchmark year 2, or both. So this is for new agreement periods. Beginning on or after January 1st of 2027, ACOs applying to enter a new agreement period would be required to have at least 5,000 assigned beneficiaries in the ACO's benchmark year 3, but you could be under 5,000 for benchmark year 1 or 2, or both. So why? CMS previously didn't allow fewer than 5,000 beneficiaries to help maintain statistical accuracy and thus ensure fair payments. However, they have evolved their financial model and calculations since the beginning of MSP through lessons learned, and they now believe that they can allow some wiggle room in this way while maintaining the integrity of their minimum savings rate, MSR, and minimal loss rate, MLR calculations. And part of this has been determining acceptable statistical confidence intervals. So they're getting more flexible. So why aren't they proposing it then prior to January 1st of 2027? Essentially, the application cycle, as many of you know, for agreement periods, it's starting on January 1st of 2026. That's already underway. So if this proposed rule is finalized, it doesn't finalize till November of 2025. So at that point, they're already going to be preparing to grant or deny applications for agreement periods in 2026. So that's why they can't do it any earlier. They have applied some safeguards to this. So if you're listening in and you're a smaller ACO or you tend to be on the cusp, if you're entering with fewer than 5,000 in benchmark year 1 or 2, you have to enter in the basic track. Next, they're proposing an alternative performance payment limit and loss recoupment limit during the financial reconciliation in any benchmark year to safeguard the overall financial integrity of the shared savings program. And then they also propose to exclude the ACOs that fall below 5,000 assigned beneficiaries in any benchmark year from being eligible to benefit from the policies that provide certain low revenue ACOs participating in the basic track with additional opportunities to share in savings. So really no double dipping, essentially. Next slide, please. So additional proposals. What else is CMS proposing? Well, they're going to revise the definition of a beneficiary eligible for Medicare CQMs. And when are they going to do this? So this one, unlike the previous one that we were just looking at, this is actually going to focus on retroactively applying. So if the proposed rule does finalize, this will retroactively apply to the beginning of the 2025 performance year if it's finalized. And so why are they doing this? CMS, basically, they're attempting to reduce the confusion related to what patients should be included when reporting MCQM data in the APP program. How is it going to reduce confusion? Essentially, it's meant to align the two lists, because y'all get two lists. I'm sure you all know that. It can be confusing. So they want to align the two lists by reducing the ACO's burden in the patient matching that's necessary to report Medicare CQMs, because the list of beneficiaries eligible for Medicare CQMs would have greater overlap with the list of beneficiaries that are assignable to the ACO. So they're looking to have greater overlap and better alignment. Specifically, they believe the definitions will be more closely aligned and would mean that for most ACOs, the large majority of an ACO's beneficiaries eligible for Medicare CQMs would actually be part of the list of beneficiaries assignable to an ACO. So what's the MCQM roster going to look like if this is finalized? It will probably have an additional variable to the quarterly list to flag each beneficiary who had a primary care service visit. So again, the new definition word for word is proposed as at least one primary care service with a date of service during the applicable performance year from an ACO professional who is a primary care physician or who has one of the specialty designations included, or who is a physician assistant, nurse practitioner, or clinical nurse specialist. So is anything going to drastically change for you if you're reporting MCQMs? Not really. You're still going to receive the roster. You're still going to load that into Patient 360. So your process really isn't going to change if you're reporting MCQMs, but CMS believes the beneficiary population would be based on a list of beneficiaries that better reflects your ACO's assigned population. So overall for this, better alignment. That is the hope. Next slide, please. These are just routine changes. that we just want to go through briefly with you. Routine changes to the list of CPT and HCPCS codes that are used to define primary care services for the purpose of assigning Medicare fee-for-service beneficiaries to an ACO. A little background on this: previously finalized in past years, Medicare fee-for-service beneficiaries, they're assigned to an ACO based on the utilization of primary care services. Primary care services are defined by a specific list of CPT and HCPCS codes, and CMS periodically updates these lists through rulemaking, as you know, to be based on any changes in codes recognized for payment under the physician fee schedule, or to incorporate other changes specific to SSP. Additionally, CMS proposes to add the enhanced care model management services. You can see right there and what those codes are, the HCPCS codes for those. And the enhanced care model management services codes, which allows payment when behavioral health integration or collaborative care model services are provided in conjunction with advanced primary care management. So this is important to collaboration between primary care and other healthcare providers, such as behavioral health. And they're deleting the social determinants you can see here of health risk assessment services because it's duplicative with already existing codes. So really just cleaning up a bit. Next slide, please. So additional proposals looking to remove the health equity adjustment. So the proposed removal of the health equity adjustment will retroactively apply to 2025. Why are they removing this adjustment? There are basically, we know there's other incentives already available for ECQM, CQM, all payer submissions, such as the complex organizational adjustment, as you're aware of. ECQM has additional bonus points. So they want to remove duplicative incentives. EUC details. So this actually will probably help some folks. They want to expand the application of the quality and finance EUC policies to an ACO that's impacted by a cyber attack. So this includes ransomware and malware. I mean, this stuff is happening left and right, and so I think it's really important that they addressed this. CMS determines how an EUC applies to an ACO by considering these scenarios. So take a closer look at this if you're impacted at all or you think you may have to do an EUC. They look at 20% or more of the ACO's assigned beneficiaries reside in an area identified under the quality payment program as being affected by an EUC, so 20% or more of the beneficiaries, or the ACO's legal entity is located in an area identified under the quality payment program as being affected by an EUC. So here's some questions I want you to ponder, and this is probably what we're going to provide comments on as well with these scenarios. Expanding the EUC to include cyber attacks in the pool of reasons is helpful, but the scenarios of the 20% beneficiaries or the legal entity location don't cover all the conditions, at least we've seen here at Patient 360 with our various ACOs. We have to think about things like TIN composition and location within the ACOs. For example, we have ACOs that have TINs all over large states and also in multi-state locations. There's instances where only one TIN may be severely impacted by a cyber attack or natural disaster and is eligible for the EUC. However, that one TIN is more isolated and doesn't consist of 20% of the actual ACO's assigned beneficiaries. So we plan to ask CMS to either better define how to apply the EUC in these circumstances or to permit the ACO to submit their data without data from the impacted TIN, right? So we just need a bit more clarity, and that's what we're going to comment on from the Patient 360 point of view. Next slide, please. This is really quick. It's just a gentle reminder here that Measure 113 has definitely been finalized for 2026. I know you all saw that colorectal cancer screening. And, as many of you know from experience with trying to get data for Measure 112 here in 2025, it's a good idea now to start educating your TINs on the measure, as well as having them connect with their EHRs as soon as possible so everyone is well prepared for 2026 and can really hit the ground running. So measures on the roadmap, next slide. We're looking at noting the measures on the roadmap for the APP plus set in 2027 and 2028, and those are substance use disorder and the treatment and adult immunization status. And then for CAPS, they are planning to change the protocol to add webmail, which is good because the response rate will actually increase. And some of the numbers, like they looked at the web-based survey and they compared, and they got a better 43% response rate compared to a 28% response rate for mail phone only. So that's a pretty decent uptick in response rates. So that's really going to help. And then removal of the measures, CMS is proposing to remove quality measure 487, that's screening for social drivers of health. They were going to start that in 2028, but they're not going to. Why aren't they going to? It's their continued attempt to eliminate measures that merely tick a box to show something was done, because that doesn't really measure anything. It's process. They really want to get clinicians acclimated with processes, and that's important, but they're looking to get folks to graduate to outcomes that have impact on quality of care. Directly from CMS, this is what they said. CQM 487 is a process measure. It assesses the percent of adult patients who are screened for social drivers of health. Rationale for removal, it doesn't align with CMS's renewed focus on outcome measures, nor on CMS's proposal to revise the definition of a high priority measure to remove health equity. So again, really looking at focusing on those outcomes-based measures. So what's on the horizon overall for the APP program? I can tell you from reviewing the last several proposed rules and final rules that a significant number of RFIs have been released related to FHIR. So FHIR is where it's at the moment. And we know that this just isn't the seed of a good idea. That's not going to crystallize. This is going to happen. And it's the how and the when that's going to become extremely important. And that's why all stakeholders listening today, really, if you can, try to make best efforts to respond to the FHIR RFI and the current proposed rule if you have strong opinions about FHIR, especially the timing and implementation. CMS is planning to streamline the quality measure collection types as well. They really want to focus on ECQMs and Medicare CQMs and retire the MIPS CQM collection type, beginning with the 2027 performance year. And then they also plan to sunset Medicare CQMs by 2030. So things are happening. I think it's going to happen. We have to be really careful about the timeline of this and really make sure that we're commenting on the fact that we may need more time for this type of transition. So what can you do now to prepare? Start reporting ECQM collection types as much as possible. Easier said than done, I know, and that's why I'm saying try to do that now. This means TIN education. It means urging your member TINs to ensure their EHR products are 100% 2015 cert. Aside from this, putting your ACO ahead of the game for the future, reporting the ECQM collection types now at present, it does have other benefits. Some of those, your performance scores are typically going to be better because the benchmarks don't top out because the data can't be manually manipulated. Also, it organically includes the entire eligible population, so you don't have to worry about tracking data completeness. The data is always 100% complete when it's sent using the ECQM collection type. Also, there's bonus points awarded to measures that are submitted under the ECQM collection type. So again, lots of benefits to submitting ECQM collection type now rather than waiting. And overall for this slide, the gist is please comment on the FHIR RFI if you're concerned at all with the timing, operational, and technical aspects of FHIR rollout. I think that, again, it's going to happen. It's a matter of creating effective and meaningful comments to help maybe perhaps delay it a bit or fine tune it a bit. Next slide, please. So this very quickly, I think most ACO staff know about promoting interoperability. Everybody that's attending today is aware that it was previously finalized in 2025 that PI is required for MSSP ACOs. Why did CMS do this? To better align SSP cert requirements with the MIPS PI requirements. So that's the why behind this. In order to report the PI category, I think everyone knows this, but I'll just give a quick shout to it. You have to use certified 2015 certified EHR technology. You have to report on all the objectives and the measures required under PI, including the attestation statements as required by CMS for the continuous 180-day reporting period. You can be excluded from reporting on the MIPS PI category if you meet any of the exclusions listed at the bottom of the slide, right? So there's the special statuses. And then the next slide, we actually provided you with some links, right? So if you're not sure about your PI eligibility, you can use the tools and the links on the slide to check the status of your ACO and member TINs. PI can indeed be reported by Patient 360. So if you need to report PI, just let us know. We can assist. July started the 180-day time frame. So we can start receiving data now from January to July, and you can cross PI off your list now if you wanted to do that. It's one less category that you have to worry about at the end of the year. So next slide. What are our action items? What can we do now to be prepared for 2026 if we're an MSSP ACO, and also to be successful with our data here in 2025? First of all, make your voice heard through public commenting. Following the formal public commenting process, and we're going to detail that at the end, you're going to get to just plug and play, which is great. You're not going to have to construct anything. We've kind of laid it out all for you. That's going to be the best way to influence CMS to consider and possibly act upon your position. CMS should have released your Q2 MCQM roster by now. So if you know your ACO can't report all ECQM collection type, upload your MCQM roster now to Patient 360. That's going to ease some of your burden. And then you want to check your PI eligibility as soon as possible to determine if you have member TINs who are required so that this doesn't slip through the cracks and you're not scurrying at the end of the year to manage another category. So again, make your voice heard through public commenting, upload your Q2 MCQM roster, and find out about your promoting interoperability eligibility as soon as possible. Now we're going to hand things over to our Clinical Quality Director, Deanna Hayes. She's going to tell us a bit more about the changes that we can expect for MIPS and MVPs. It's probably going to be faster because, again, we're going to spend a lot of time on the new ASM program model at the end.
Thanks, Amanda. We'll spend a few minutes on MIPS and give it right back to you. Hi, everyone. Like Amanda said, our intent is to give you more than you would otherwise get when you just read the rule or read the fact sheet or attend a webinar. We do have plenty of content that's laying out the basics and the facts. But to start off, and the topic of this slide really delves into some of those insights and overarching themes that we'd like to share with you. General priorities underlying the proposals in the Medicare Physician Fee Schedule final rule, and particularly MIPS, include advancing a lot of the important priorities that CMS was working on before. They're continuing to reduce provider burden. They want to advance interoperable digital quality measures and FHIR, like Amanda said recently. They're continuing the shift away from process measures to outcomes and cross-cutting comparability of measures. Now, those bullets 3 and 4 on the slide there, my kind of read of the tea leaves is that they're leaning in more to cross-cutting comparability again. They've done that in the past, moved away from it. They're continuing the march to replace traditional MIPS with MVPs or MIPS value pathways. And the last 2 bullets really underscore some of the differing priorities of the new administration. It's all with the continued effort to improve quality and care and reduce costs in healthcare, but taking a little different approach to doing it or different levels of prioritization. So there's an emphasis on preventative care and proactive health management, and we're shifting away from a specific named focus on health equity. And so these are themes that you'll see across many of the next slides. It's still important to detect and address health disparities, but the focus is shifting now to, yes, you should gather data on health equity, on disparities, but you should use that to improve your outcomes. And that's what we want to measure, is the actual outcomes. Next slide, please. Also, just some real general proposals. The performance threshold is proposed to remain at 75% through performance year 2028. No changes to data completeness. The changes to the clinical quality measures inventory that we'll overview on the next slides would leave us with a total inventory of 190 measures, 3 of which would only be available in certain MVPs, and removing health equity from the definition of a high priority measure. Next slide. Advance. We do have some breaking news for you. We were going to tell you to watch out for the feedback in 2024. Might be a little background on your end, Amanda. And but we just got some breaking news that the 2024 MIPS final scores and targeted reviews, CMS apologizes, but they are going to be delayed until the fall. So we're kind of disappointed about that, as I'm sure you are, but we wanted to share that with you in case you had not heard it yet. On the next slide, briefly, CMS is proposing to add 5 new clinical quality measures. The detail is on the slide for you to read at another time, but the gist of these additions are consistent with the renewed emphasis on outcome measures and other priorities that CMS continues to advance, one of which being increasing the number of kidney transplants in this country. So that second one there about kidney is part of that initiative. On the next slide, CMS additionally proposes to remove 10 CQMs. If you just look at items 1, 2, 3, and 4 that are bolded there, the point of this slide, or at least talking with you, is to just kind of emphasize the reasons, the general reasons for the removals. You can see 5 of them are being removed just because they're topped out. That's nothing new or unexpected. Items 3 and 4 are not unexpected either. And the last 3 measures, process measures and no longer addresses a high priority area, you can see that's consistent with the current administration's shift away from gathering data, screening, process focused on health equity and vaccinations to let's replace this with things that are outcomes focused. On the next slide, CMS also proposes to make substantive changes to 32 of the clinical quality measures. And as Amanda said, we have in the lower right-hand corner of each slide, at least some of the page numbers that you can go to for a quick reference and see all of this stuff in its glorious detail. So we urge you to take a look at that. The changes are basically reflected of routine updates and a whole hodgepodge of things. Just a tip to make sure you notice whether the changes were specific to a certain collection type or not. They're also modifying specialty sets as they always do. So if you are someone who attends to specialty sets, you might notice certain sets that have no modifications proposed, substantive changes, and you can see there are multiple changes to 48 sets. Again, that is just mostly in following with other changes that we're detailing elsewhere. The particularly interesting thing that I wanted to spend a minute on was the topped-out measures benchmarks list. This is a relatively new thing that is a good thing for small practices and specialists, particularly, that are impacted by limited measure choice. So knowing that CMS always tries to work out topped out measures when they become topped out enough that they're no longer showing a gap in care, no longer driving improvements in care, the point is to remove it in favor of other measures to drive other areas. But the challenge is for certain specialty sets and MVPs where they already have limited choice of measure, that kind of creates a disadvantage. So they have a new way of calculating that will not only help with specialty sets, but also brand new, certain MVPs that are impacted by measure choice. Next slide starts to go into cost measures. Briefly, the biggest thing we want to call out on this slide is that we're excited to see there is a 2-year informational only feedback period that would begin for any new cost measures starting in 2026. Okay, there are no new cost measures being proposed for 2026. And we have had some challenges with existing cost measures where it sure would be nice to have a way to give ongoing performance feedback during the performance year. And and others have pushed back strongly on that issue. We know CMS is aware, and they consistently have said, we just can't do it because of the way the measures are calculated. So our kind of insight is we take this as their best effort to at least help with that situation. You get a 2-year informational feedback only period for any new cost measures so you can get familiar with it without worrying about your score being affected, but not until the next round of new cost measures. Let's move on to the next slide. Moving on to improvement activities. The quote at the top of the screen, again, just underscoring these themes that are weaved throughout not only this document, but other CMS current initiatives. They want to demonstrably improve patient outcomes while also being efficient with our healthcare resources. And we want to prioritize also prevention, nutrition, and well-being. That's a new thing for this administration and this CMS, is the emphasis on prevention, nutrition, and well-being. So you'll see these themes. As you can see down below, we have 3 new improvement activities being proposed. One in particular that's especially interesting is the use of artificial intelligence improvement activity, where they're calling for a specified field, a data collection field in patient safety reporting systems, where you can record events that can be attributed to artificial intelligence. Changes to 7 IAs, and as far as changes to subcategories, again, we see one of those overarching themes where we would be removing the special subcategory for achieving health equity and replacing it with advancing health and wellness. And then as far as removing IAs, again, the content is on the slide for you. We see some of those same themes reflected in what they are removing: process measures in lieu of let's move on to outcome measures. For promoting interoperability, on the next slide, they have a number of proposed changes that are generally welcome, and for the sake of time, I'll leave those on the slide so that you can glance over them at your leisure. But the one particularly noteworthy one is at the bottom, adopting a measure suppression policy when there wasn't one before. I want to spend a little more time on MIPS value pathways. As a reminder, MIPS value pathways are streamlined subsets that require only 4 quality measures, and they're intended to make things a little easier to understand and have streamlined choice. They are intended to replace traditional MIPS. We can't say that enough, so we want to offer a success tip to you with a reminder that traditional MIPS is going away. They don't have a specific date. We've heard maybe 2029, but they have not set a date. We urge you to consider reporting both traditional MIPS and MIPS value pathways. Why? It's minimal extra effort to you, and CMS is going to give you the best of the 2 scores anyway, and it lets you really take advantage of this crucial time to practice and ramp up and be ready to hit the ground running when traditional MIPS goes away. CMS also proposes 6 new MVPs, and moving to the next slide, proposing changes to all 21 existing MVPs. Now, a lot of these modifications, again, are just carryovers from changes to quality measures, improvement activities, removing that quality measure 487 for social determinants of health, and so on. If you have not yet really taken the time to look into the MVPs, we encourage you to do so. Look for the MVPs that pertain to your specialty area, such as number 19, the rehabilitative support for musculoskeletal care. We know applies to a lot of our clients. And I'll have a MVP table in just a couple of slides so you can kind of see what it looks like. But before we do that, we want to talk about proposed changes for specialists and subgroup registration. The background and all the rationale is on the slide for you, but the upshot is just what you see in bold there. The point is that they want to allow small multi-specialty practices to retain the ability to be able to register and report as a group. So as of 2026, what they had already finalized was that multi-specialty groups would no longer be able to register using that designation of multi-specialty group. But they don't want to further disadvantage small multi-specialty practices by forcing them to then further subdivide into groups. So the point is, if you are a small multi-specialty practice, you can still register and report as a group for your MVP so that you at least maintain the power of the number of providers that you have. And all you'll have to do is attest to whatever your single or multi-specialty focus of care is. Next slide shows that MVP table, or actually just a portion of an MVP table. If you have not yet seen or spent time with the MVP tables, just so you know, this is only part of one. What I cut off so that it would fit was the list of improvement activities. But you can see these MVP tables list the quality measures, the cost. The other portions show the foundational promoting interoperability measures and IAs. What's newly being proposed is to add this clinical grouping section. It's kind of a stratification of the contents of the MVP, and they're just trying to further reduce burden by making this a little easier to understand so that you can see what best aligns with your specialty. Now on the next slide, just some important action items that we would like to leave you with before we turn it back over to Amanda is, like I've been saying, we encourage you to determine whether or not there's an MVP for your specialty. Keep in mind they're continuing to evolve that. We've got 6 new ones this year, possibly more to come in upcoming years between now and when traditional MIPS is fully sunsetted. But you can use this resource shown here and/or look up the tables on the previous slides that we mentioned. One thing it's really important to keep in mind is that you have to register by December 1st of the performance year. Don't forget to register or you'll do all that work and submit and they won't be able to accept your data. Third item, if your selected MVP has CAPS for MIPS, you have to register to report the CAPS for MIPS survey by June 30th of the performance year. And then make sure you get the most out of submitting your data and being able to monitor your performance by making sure all the switches in your Patient 360 portal are flipped so that you can see the performance results for your MVP, your traditional MIPS if you'd like to monitor both, and make sure your clinicians know where to document within the EHR for your chosen measures. Make sure all the data is being collected accurately and recorded in the right place. Back to you, Amanda.
Awesome. Thanks, Deanna. So let me just make sure. I'm going to do a little check-in with Garrett and Team Deanna. Are you getting any feedback or is it sounding clear? I just want to make sure there's no crazy echoes.
Oh, we're good.
All right, cool. Okay, so here we are, the star of the show, the new ambulatory specialty model, okay? So the CMS Innovation Center is proposing a new 5-year mandatory ambulatory specialty model to begin with the 2027 performance year and ending in 2031. They are proposing that this will be a mandatory program, not optional. This new model is going to assess performance based on the measures and activities included in the ASM, which will be quality cost improvement activities and promoting on interoperability categories with a primary focus on quality and cost. So this is the same categories as MIPS, right? These are the same, and MVPs, very similar, but we're going to review in the next few slides. There's a much more emphasis on the quality and cost categories. Participants will be eligible to receive a negative, a neutral, or a positive payment adjustment on Medicare Part B payments 2 years after the performance year. Again, very similar to MIPS and MVPs, but there's definitely nuances regarding the payment adjustments that we're going to review in the next few slides, namely that it's not a budget neutral payment adjustment program. It's very different. So we're going to review that in a minute. What's the intention of this new model? So we talked a bit at the beginning about we want to try to provide information about intention. So why? This model is intended to help patients stay in good health and keep their cost of care low by promoting prevention, upstream management, and timely targeted care, specifically of heart failure and low back pain. So the key here is prevention. They're targeting a big ticket item. It's very well known that annual costs of low back pain and heart disease are massive. So the program is designed to drive patient-centered outcomes, focused care, while reducing what CMS says as spending that represents low-value services and major cost drivers. Next slide, please. So eligibility. Again, there's a key difference here. This new model is to propose to be evaluated at the individual clinician level only. At the time, there's no plans to allow group reporting for ASM. So how is CMS going to determine if you're eligible and required to report the ambulatory specialty model at the individual level? Again, there is not going to be any group reporting, at least that's what's been proposed. First, you're going to have one of the defined specialty types listed on your Medicare Part B claims. For the heart failure cohort, CMS is looking at cardiologist only. For the low back pain cohort, you can see on the slide, it's going to be anesthesiology, interventional pain management, neurosurgery, orthopedic surgery, pain management, and physical medicine and rehabilitation. CMS is also going to check to see that a clinician is billing claims for Medicare. Next, the clinicians must meet the case minimum of 20 attributed episodes for the MIPS episode-based cost measure applicable to the cohort 2 years prior to the performance year. For example, a cardiologist who has at least 20 episodes attributed to their NPI-TIN combo for the MIPS heart failure cost measure here in 2025 would meet this eligibility threshold for being an ASM participant in 2027. Finally, CMS has proposed that ASM participants be located in one of the selected mandatory geographic areas. CMS will use a stratified random sampling method to select certain geographic regions and accounting for factors like population density, high-low spending, and high-low volumes of the target conditions. ASM participants would be exempt from MIPS reporting for each performance year where they are eligible and required to report on the new ASM. So if you become eligible as an individual to report the ASM, you will be exempt from reporting MIPS for that performance period. And now we're going to go into with Deanna. She's going to talk about the actual measure sets. So the measure sets that you're looking at and that you're going to see for low back pain and for heart failure, these are required. So everything in the set is going to be required. She's going to talk to you about these measures, and then we're going to provide some actionable items about what you should consider during the proposed rulemaking comments that you're going to make. Over to you, Deanna.
Thanks, Amanda. So we're really gearing this toward what you might want to really reflect on in case you're required and determine whether or not you'd like to submit public commenting to agree or disagree or suggest alternatives. Again, the page numbers at the bottom of the slide give you a chance to dig in and understand these better. Briefly, the first one, the risk standardized claims-based measure is important. It goes without saying that unplanned admission rates are expensive, so they're planning to prioritize this one. The second two, 008 and 005, are intended to drive practice guidelines-based use of medications that have been shown consistently in research and through practice guidelines to improve management of heart failure and heart disease, controlling blood pressure. Functional status assessments for heart failure is currently a process measure. It would probably continue to be a process measure for the first year in 2027, where you just say yes or no, we did a functional status assessment with this patient, but their intention would be to respecify it into a full-blown outcome measure, specifically a patient-reported outcome performance measure. And the heart failure episode-based cost measure is currently involved in the corresponding MVP, so it made sense to pull that over. If we move over to the low back pain potentially required quality and cost measure set. The first one, MRI for lumbar spine, is the claims-based measure. It would be respecified. It's currently in the hospital outpatient quality reporting program, and as such, it's specified on the facility level. So they would need to do testing, reliability and validity, and such, and make sure that it's suitable for the NPI TIN level. High-risk medications is important because muscle relaxants and so can increase the risk of falls in older adults, very expensive. Depression and BMI are common comorbidities and associated with worsening of low back pain. So that's part of the rationale behind 134 and 128. And CQM 2020, we want to spend just a little more time about. This is functional status change for patients with low back impairments. This one, because here at Patient 360, we have specialized subject matter expertise in research and clinical practice for low back pain, and we have strong measurement science familiarity with this particular measure. So we wanted to share a little bit with you about what we plan to submit to CMS in our public commenting, and invite you to reach out to us in case you'd like to align or discuss or coordinate a response. So feel free to reach out to us if you're interested. Briefly, our position is that we agree with CMS that patient perceived functional status is absolutely a crucial construct to help assess the effectiveness of low back pain. We are concerned, however, that while Measure 220 has a free public access website that provides computer administration, calculation, and scoring, there are some pretty notable barriers to ease of access and especially interoperability that we think are going to make it tough and prohibitive to the widespread use that CMS intends. So we intend to encourage CMS to work with the measure steward on this issue. We also plan to offer alternative solutions, for example, an existing QCDR measure called MSK3, which is also a pro-PM for assessing functional status and low back pain, has components that may be more suitable for widespread accessibility and interoperability. We also plan to comment on an additional pro-PM measure that CMS is considering called the Patient Activation Measure. It's Quality Measure 503. And we also plan to respond with our agreement that patient activation is a very important construct in managing better functional care and costs in low back pain and heart failure. But it's a proprietary measure. It's a highly proprietary measure, and it kind of has a lot of questions. It has 10 to 13 questions, which is a higher response burden for the patient than is ideal, especially when you consider how many other things we're asking the patient to answer. We plan to recommend that CMS either respecify the existing or develop a new measure that features the four-question version of the promised self-efficacy. It's widely accessible, well-suited for interoperability, and 4 questions is a much lower patient burden. Back to you, Amanda.
Thanks, Deanna. Okay, so I'm going to be pretty brief with IAs and promoting interoperability in the program because interestingly, how they're going to structure this is you're going to have to report improvement activities and promoting interoperability, but you're not going to get any points for reporting. And we're going to show you that on the next slide in a second. But essentially, if you don't report either one of these categories, which are going to be required, you're going to get a deduction from your final score. If you do report them, you don't get anything. So it's not like what you're used to when you're reporting IAs now through MIPS or MVPs, you get the 15 points just for picking them. That's not going to happen anymore. You get nothing. And you'll be able to see a full breakdown on that in the next slide. And I also want to stress with you that for promoting interoperability, even if you're from a small practice, so we already know eligibility is going to be based on individual level. So you're going to have to submit at the individual level. But even if you're an individual that's from a small practice or a solo clinician, they're still going to provide a deduction from your score if you don't do the promoting interoperability category. They're going to make up for it, and I'll show you that on the next slide, but I just wanted to make everyone aware that these 2 categories still exist. You're going to have to report them at an individual level, and if you do them, you get no extra, you don't get points for it. If you don't do them, you get a deduction. Let's pop over to the next slide and see what this looks like. So basically, in order to calculate a score from 0 to 100, what they're going to do is assign an ASM performance category weight of 50% for both quality and cost. The scoring adjustments are going to be applied to the final score based on reporting requirements and performance scores in the improvement activities and promoting interoperability categories. However, like I said, they're not going to have a category weight. Why are quality and cost going to be worth so much? Why are they structuring it like this? So these weights are basically aligning with the ASM goal of decreasing the cost of care for beneficiaries with targeted chronic conditions and increasing the quality of care. They're also hoping that this is going to broaden the distribution of the final scores. So CMS doesn't intend on making the small practice PI exception that we see for traditional MIPS and MVPs, like I said. Instead, what they'll do is they'll add 10 points will be added to the final ASM score for small practices, and 15 points will be added to the final ASM score for solo practitioners. So basically, if you're not on CERT, it will be a wash, right? If you're a small practice or a solo practitioner. But the bottom line here is that CMS really is pushing for the use of CERT, although they do acknowledge that they've received feedback from small practices and solo practitioners that face challenges in their ability to participate in MIPS due to cost to implement and maintain CERT, staff and training costs, limited staff capacity to manage the complexity of the program. So they get it. And that's why I think that they've made these adjustments to the final score if you are from a small practice. But again, it just makes it a wash. So I think they really are pushing in the direction towards CERT. Next slide, please. So it's going to get a little confusing because we're not talking about budget neutrality. So let me break this down. In order to earn a final score out of 100, CMS is proposing that an ASM participant has to meet the data submission requirements of the quality performance category, which means meeting that data completeness threshold of 75% on the quality measures. We're used to seeing that, and must receive a performance score for both quality and cost categories to be eligible for a payment adjustment. The table on this slide, it's showing the different scenarios of the final scores and the corresponding payment adjustments. So for example, if you earn a score for both quality and cost and therefore earn a final ASM score, the ASM participant will be eligible for a positive, neutral, or negative payment adjustment. ASM participants who meet the quality data submission requirements but don't receive a score for the quality or cost categories will not receive a final score and will be assigned a neutral payment adjustment. So it would be possible that you don't receive a score for quality if the measures don't have benchmarks or if they don't meet the required case minimum of 20. Similarly, it's possible to not receive a score for the cost category if you don't meet the 20 patient case minimum here as well. What's really important here is that if an ASM participant does not meet the quality data submission requirements of 75% for each quality measure, you would receive a final score of 0 and the maximum negative payment adjustment, which is set by CMS, and it's called the ASM risk level. So we're going to look at that on the next slide. So here we are with the incentive pool. So the ASM incentive pool, essentially, this is going to be different than budget neutrality. So we have to shift gears here. It's a fixed percentage of the total amount of Medicare Part B covered professional service claims paid to ASM participants with final scores that would be distributed in the form of scaled payment adjustments during an ASM payment year. CMS is going to calculate the ASM incentive pool using the ASM risk level for the appropriate payment year and the ASM redistribution percentage. So for example, we know that the first 2 payment years will have a risk level of 9%. We know that CMS proposes to set the redistribution at 85. And let's assume that the sum of the ASM participant Medicare Part B payments totals $1 billion. Multiplying these values together is going to get us a $76.5 million ASM incentive pool. To complete the scoring and payment adjustment calculation, CMS is first going to calculate the incentive pool. I know, right? That's why we have the percentages over there on the left in that left tile. So they're going to calculate the incentive pool, calculate the adjustment factor, which is the percentage value calculated using your final score, the appropriate risk level percentage, and then CMS's scaling factor. And they're also going to calculate the payment multiplier and the overall payment adjustment. One thing I did want to note as well is that they're going to calculate separate incentive pools for each cohort. So those incentive pools that we're talking about will be completely separate for low back pain and for cardiology. So the main takeaways here are that the payment adjustments are very different than what you might be used to for MIPS, which uses a budget neutrality method. Instead of using a performance threshold and negative payment adjustment to fund the positive payment adjustments, which is what budget neutrality is, for the ASM program, CMS is proposing to have a separate ASM incentive pool calculated for each cohort. CMS plans to notify participants of their payment adjustment information through the ASM performance reports. So again, this is a brand new program. There's going to be a lot of information released, additional information, and that's why this is going to be very critical for us to comment on. Next slide. Really quickly, because we only have a couple of minutes left, and I just want to touch on the plug and play aspects of this session so that you feel like you can easily have at your fingertips everything you need to provide meaningful comments. So right here, I just want you to know there are a ton of RFIs in this proposed rule. The one that we're going to spend the most time on, Patient 360, publicly commenting, is the RFI. I really think the RFI for FHIR, that it's going to happen, but we have to be really careful in our request for information and talking about the timing of it. I think there's a lot of operational and technical aspects that really need some weeding out and need additional time, especially if FHIR is obviously requires the use of DQMs. When we all think about this collectively, we've all been working on getting ECQMs to patient 360. That already is its own series, has its own series of issues, right? It's not perfect and it's not seamless. So we can't just jump from ECQMs to DQMs in just a couple of years and expect that it's all going to work out fine. So I think we really need to comment on that. If you can, please comment on the RFI. I provided the page numbers there for you as well. Garrett's just going to do a final polling question.
All right, let's put it up there. And by the way, we know we're going over, but that's all right. If you want to stick with us, we'd love to have you. Pulling up a question for you on your screen. In the past, how many times have you submitted commentary on this proposed rule? Never? Once or twice? Or do you do it annually? We'll give it maybe about 10 seconds for
We've got a lot of nevers. Okay, this last section I think is going to really help everyone.
Yeah. We'll close it down in about 5 seconds here, 5 long seconds. 4, 3, 2, 1, and show you the results. Boom, there we go.
Okay, good. Then I want you all to be able to use this, right? So next slide. Everything that you need about the proposed rule is on this slide, and you just have to click, right? We provided all the links. You don't have to dig around to try to figure out where it is. All the version, the published version, it'll get you right there by clicking on those links. And then the next slide, what we did is a plug and play for you. So if you've never submitted comments, which is like 70% of the folks that are listening in today, take this slide, slide 44. Look at it. August 30th, the date is on there. Everything that you need to have in your submission is on here. You can literally copy and paste this. And where you submit your public comments, you don't have to dig around and try to figure that out either. Look at the left, that little bullet there that says submit public comments electronically. Boom, you can click right there. You can copy and paste all of this information that I have here, because you have to include this in your comments. And you can put it right into a Word document, convert that to a PDF, and upload it. On the next slide, composing the public comments. Just want to give you this thought. A lot of times I will go in and I will look at other folks' comments, and it'll be like a one-liner. You can't. You have to have all of the details that we're telling you here, right? It needs to include the section being referenced, the page number, and what CMS is stating, and then including the issues that you may have, who it's going to impact, and your organization's potential alternate solution. I can't tell you how many comments that if it's a one-liner or if it's just, I don't like this, we don't want this program, but you're not providing an alternate solution, they're not really going to pay attention. We have been following at Patient 360 this model for 10 years now in public commenting, and we actually see that they do respond to our comments, because I'll see an actual comment that we've made in the final rule. They'll say, commenter said the following, and I'll see direct quotes from comments that we have positioned within the public posting, because we've done it in this format, and this is absolutely the recommended format. So take a look. Topic, you put right there, the page number, where you found it, what is CMS saying? We seek comments on the following, put the quote, and then the issues. Here's the issue that we have with the proposal. The direct impact. Who is this going to be an issue for? Who is it impacting? Which stakeholders? And then your alternate solution. That is the most important part of publicly commenting, is providing your alternate solution. So if you think that the program that we were just talking about, the ASM model, not a bad model, right? It's the seed of a good idea. How are they going to really launch this in 2027, right? There's operational things that need to be worked out, all of that. So what you want to think about if you're going to propose as, well, the ASM model, no, we don't want to do it. That's not going to be a good proposed comment. You want to talk about, well, if we launch in 2027, this is who it's going to impact. This is what it's going to impact. We don't have the technology in place. We need more time for cert, whatever the case may be. And then your alternate solution, you'd want to come up with something such as, well, we'd like to delay. We think if we had additional time that this would be more meaningful, maybe to 2028 or 2029, or we'd like the program to run concurrently with MIPS. So you need to provide alternates. That's gonna be the most meaningful way and the most effective way to make sure that your voice is heard for those public comments. And then finally, after submitting your comments, you can go and take a look at this after, but you will get a receipt. And I just showed a copy of ours here, what that looks like, what you can expect after you've already submitted your comments. And then final recommended action items on our last slide here. Again, I can't stress enough with everyone that it's really important that you're actively engaged and logging into the QPP portal on a regular cadence, at least once a quarter. We're not your security officials for your organization, so we don't have access to the same information as you. And there's a lot of information. It's related to your eligibility, your scores, your payment adjustments, all of that stuff. So it's really important that you log into QPP on a regular cadence. Medicare shared savings programs should consider reporting on Medicare CQMs in addition to all payer data. So it's great to dually submit because CMS will take the better of the two scores. Same for folks out there that are doing MIPS and MVPs. And then please do comment on the proposed rule. And the last slide here, Garrett's just going to wrap things up and let you know about the virtual booth.
All right. Thank you, Amanda. Thank you, Deanna. I know, gosh, there was a ton. You weren't kidding. There was a ton of material to cover here. And I know, thank you for those of you who've stayed over a couple minutes. As we wrap up, first of all, we're going to send out a link to the recording to where you can download this and get the slides and all that, because I know you're going to want to review it. So just just hang on. Someone will reach out. By the way, if you also submitted a question, someone will reach out via email to answer that, because I know we didn't have a time for audience questions today. All right. Well, as we close down, I would encourage you all to head over to bbcexhibithall.com. And if you're curious at all about Patient 360 and what they're doing, want to get in touch with them, you can, of course, get there through this booth and reach out to them through there. Or if you would like to reach out directly, if you want to go to the last slide here, there is John's information, and he will point you in the right direction, or I'm happy to facilitate an introduction as well, whatever's easier. Thank you all again so much. Amanda, thank you. Deanna, thank you for a fantastic presentation. Hope you join us for the next one. Until then, have a great rest of your day.
Thanks, Garrett.